Hello, everyone. Thank you for coming today. My name is Karl Keat, and I'm a fifth-year PhD student in the Genomics and Computational Biology program at the University of Pennsylvania. Today, I'll be introducing PGxQA, a resource that we developed to evaluate the performance of large language models and digital assistants in answering pharmacogenetics questions. First, I want to introduce the concept of pharmacogenetics, which is the study of how genetics influences response to drugs. Pharmacogenetics is particularly relevant to precision medicine because the ability to predict how people respond to medication in advance allows us to better tailor treatment and therapeutics to each individual's genetic background, and therefore improve clinical outcomes. Towards this goal, the Clinical Pharmacogenetics Implementation Consortium has published 43 guidelines for 151 medications where genetics may be used to guide treatment. And sorry, I don't know why it skipped to the end there. I guess I'll loop back to the start. All right, back to the beginning. Okay, so so they've released these guidelines which have a high degree of evidence for clinical use. And in support of the use of these guidelines in the clinic, a recent randomized trial of a preemptive 12-gene genetic testing panel for pharmacogenetics found that there was a significant reduction in adverse drug reactions among those who received the genetic testing. Despite these promising results, implementation of pharmacogenetics has been limited in actual real-world health systems. Some of this is because we need to convince various stakeholders of the sort of cost-benefit balance of this approach. But also a major limitation is that clinicians simply do not receive much training on pharmacogenetics, and therefore, even when given access to genetic data, often do not have the expertise needed to interpret it and put it into actual use. Meanwhile, we all have sort of through the talks today and through previous days heard about how there's this AI revolution with large language models being applied to all sorts of different problems, including in medicine. And specifically in medicine, large language models have been introduced for applications ranging from clinical decision support, patient education, and researcher information retrieval, which are all very relevant tasks in a field like pharmacogenetics, where guidelines are very complex and require relevant expertise to interpret, which, as we've established, is at a bit of a premium right now. And in support of the use of these large language models in the clinic, researchers recently showed that GPT-4 was actually able to achieve human-level performance on the US medical licensing exam. Therefore, it stands to reason that by building large language model chatbots for pharmacogenetics, one might be able to lower barriers to implementation by making information available to patients, clinicians, and researchers in a timely manner. Despite these sort of promising initial results, it's important to note that large language models have many known limitations that might be particularly harmful in the clinic. The first and probably most famous of these limitations is that large language models are prone to a phenomenon known as hallucination, where they present their responses in a very authoritative and confident tone, even when they're completely wrong. And they're particularly vulnerable to this when the relevant information needed to answer this question, your question, is not available to the model. And so, this is particularly harmful in the clinic, where we have clinicians who often need to work with incomplete information to make judgment calls that can mean the difference between the life and death of a patient. The next major limitation is that large language models rely on static knowledge. And the top large language models from companies like OpenAI and Google are actually trained on opaque data sources where we don't know what information is actually being given to them to train. At the same time, they're unable to answer questions based on things that happened or on information that was generated after the training cutoff. And this is, again, particularly harmful in the clinic, where clinical guidelines are constantly evolving in response to new discoveries and new evidence. The last major limitation I want to talk about is that large language models have high training costs. Top-of-the-line LLMs can have over 1 trillion parameters and take millions of GPU hours to train. And even LLM fine-tuning, which has been pitched as a cheaper way of achieving domain-specific results in large language models, is still out of reach for a vast majority of institutions. This limits our ability to rapidly update knowledge in existing models and to build domain-specific models, which in turn makes the aforementioned issues of hallucination and static knowledge even worse. So in light of these limitations, we find that there is a critical need for benchmarks for large language models in clinical medicine, and particularly for more niche subsections of medicine that might not have as much coverage in things like the US medical licensing exam, which have been used as clinical benchmarks so far. So we took advantage of the Clinical Pharmacogenetics Implementations Consortium's CPIC data database, which contains structured information on the relationship between genes and drugs for a couple of high evidence guidelines. And we used that to generate thousands of questions on pharmacogenetics across several different areas of pharmacogenetics. And we were able to use these questions to then query some of the leading large language models from OpenAI, Google, and Meta, and benchmark them against our data set. The first set of evaluations that we ran largely focused on high throughput automated evaluations, where we looked across many categories and looked at all the models with thousands of questions in order to get a good sort of overview of the performance. And the sort of main takeaway from these automated tests is that GPT-4 and GPT-4o, sort of the top of the line OpenAI models at the time of this research, vastly outperformed all of the other models more or less across the board. Another interesting trend that we noted is that the way that you ask questions can influence how the models respond and also how their average case performance is. We tested this by asking the same set of questions in two different ways, where first we asked from sort of a research perspective, what are all the genes that are part of the pharmacogenetic guidelines for this specific drug? But then we asked the same question in a different way. We asked, what genes would I include in a pharmacogenetic testing panel for this drug? Say, something that a clinician might ask. And we found that when you ask it this different way, you get different performance. And anybody who's done substantial work in large language models is familiar with the concept of prompt engineering, where often, say, for ChatGPT, you need to ask it the same question in different ways to try and get a more desired result. But in the clinic, we don't want to have clinicians needing to do this type of prompt engineering in order to get correct results. So this is another aspect of large language models that will need to be improved before they can be integrated into clinical practice. The last major trend we noticed in this initial automated analysis is that the LLMs notably struggled with this one category of questions, which we called allele definition, where we asked the large language models to list the SNP IDs for all of the single nucleotide polymorphisms that comprised a specific allele that we asked for. And we asked them to return it as a list of DB SNP IDs in the format of RS followed by a string of numbers. And we believe that this is part of the reason why the model struggled so much with this particular category. These identifiers are not really similar to the type of natural language that large language models are typically trained on, especially these general purpose models are trained primarily on things like public domain books and tweets. And so therefore, they might not have as much exposure to SNP IDs like these, which limits their ability to do this type of information retrieval task. The next major axis of evaluation that we wanted to pursue was to see how LLMs deal with either uncertainty or simply unanswerable questions. And you can imagine how in real life use, typos and other mistakes made by the person asking the questions can result in a question being confusing or impossible to answer. And so in order to simulate this, we decided to first modify the base prompt of the LLMs to give them instructions to refuse to answer questions that they do not know how to answer. And then we reran first a subset of the original benchmarks under this new base prompt. And we also ran a new set of benchmarks that we generated where we misspecified the questions. We added genes that don't exist, or drugs that don't exist, or other information that would render these questions unanswerable. And we found that across all of these models, the lower performing models will happily make up an answer to an unanswerable question. But GPT-4 and GPT-4o, actually about 70% of the time, will refuse to answer these misspecified questions when given the option. They also seem to refuse to answer some of the properly specified questions about a quarter of the time, which might reflect some understanding of their limitations in answering some of these questions. Yeah. And so the last thing we wanted to do, so obviously our benchmarks were designed to be run in an automated high throughput way such that anybody around the world could take our benchmark and run it on whatever model that they want. But we did think that it would be interesting to take advantage of some of the access that we have to pharmacogenetics experts in my lab. And we basically asked them to manually review 15 of GPT-4o's answers to short answer questions and compare them to the reference answers that we had for these questions. And we had them scored on a range of 1 to 5 in accuracy, completeness, and safety. And what we found is that GPT-4o scored lower across the board in all of these categories, with particular hits in accuracy and safety. And specifically in terms of safety, some of GPT-4o's answers were considered potentially dangerous, promoting action based on inconclusive evidence. In the case of liver transplant, and anti-organ rejection medication, where GPT-4o recommended prioritizing the pharmacogenetics of the donor liver over the recipient. And while there are some individual papers in the scientific literature that suggest that this might be important to do, there's not enough evidence to make this part of a clinical guideline and to give conclusive guidance in this direction. And this really reflects how large language models don't really have, at least at present, a strong ability to weigh the quality of the sources that are in front of them. They treat all information as equally, and therefore to them, a single paper is the same as a single clinical guideline. So in summary, we developed PGxQA, the first comprehensive large language model benchmark for pharmacogenetic questions. We found that GPT-4o clearly outperformed competing models, and still, however, struggled with tasks involving numeric responses and dbSNP IDs, which don't really reflect natural language like these models are typically trained on. We found that LLMs have some ability to recognize malformed queries and therefore refuse to answer them. And we showed that human expert reviewers rated the top performing LLM, in this case GPT-4o, poorly compared to the reference responses, which highlights ample room for improvement before clinical use. But we believe that overall our resource PGxQA will be useful to track the continued development of large language model assistance in this space, especially as new models come out or as new approaches like retrieval augmented generation enable better clinical AI. Thank you, and I'll now take any questions.
Any questions from audience?
Also, feel free to scan the QR code if you'd like to read the manuscript or access the code for this project.
Okay, so may I ask you questions?
Yeah.
So, so do you have any idea of improving hallucination problems? For example, using the reliable, for example, using the reliable database combined with the LLMs.
Yeah, so I think, what you've described is sort of what people call retrieval augmented generation, right? The idea of linking a database of information to a large language model. And I think that that actually is a pretty promising approach for this type of task specifically, because as we mentioned, right, like they struggled a lot with this information recall task for SNP IDs because it's relying on the model embeddings. But since we have this database that we use to build our set of questions, you could easily link that database to a large language model and more or less just teach the large language model how to retrieve information and provide it. So I think that that would be a promising approach for solving this particular limitation, but also retrieval augmented generation helps address some of the other limitations that I mentioned, where it's much cheaper to update a database than it is to update a language model, and it allows for more dynamic knowledge and reduced hallucination risk.